Welcome to ATCM, the Emergency Medicine channel. Today we'll be discussing a case. A patient came to RIA with a history of trauma while playing basketball. So a 20-year-old female was brought to RIA with history of sudden twisting of ankle while playing basketball about 30 minutes back. On arrival, actually, she was conscious, oriented, obeying to my commands, and she was complaining of pain around the right ankle joint. At that moment, I put some ice pack over the joint and continued my examination. The primary survey, the airway was patent.
Ice pack and the elevation.
The limb was elevated. She was kept on a bed and elevated and placed ice pack.
And anything else you can do initially? It's an isolated ankle injury. So anything else you can do at this point to decrease the pain?
Splint can also, L-shaped splint can also be applied. It was also being arranged. And first I put the ice pack, then it was also being arranged. And then they went to the
patient not to move, and you yourself also passively move the thing, restrict the movement, and then ice pack elevation.
So the patient was placed on a bed and raised, the leg was raised and ice pack was kept, and L-shaped splint was also being arranged. At that moment, actually, I conducted my primary survey. The airway was patent, there was no obvious signs of any airway obstruction, and the C-spine also appeared to be normal. The spine movement was normal, and there was no C-spine tenderness. Breathing, she had bilateral equal air entry, and also vesicular breath sounds were heard on all lung fields, and also there were no added sounds. Respiratory rate was 20 per minute, and she maintained a saturation of 98 in the room air. The circulatory part, she had good peripheral pulses on all 4 limbs, including the affected limb, and the pulse rate was 98 per minute, and blood pressure recorded was 130 by 80. And at that moment, I put a 2 large bore IV cannula, 18 gauge was.
The peripheral pulse is one is felt in all the limbs.
All the limbs.
When compared with the corresponding normal limb, what is the pulse volume,
pulse
tension,
volume,
all these things equal or not, that also is
it appeared
more
to be
important.
Equal, on both sides. And 2 large bore IV cannula was inserted of 18 gauge, and she had complaint of a pain score of 7 by 10. So injection paracetamol 1 gram IV was started. And the disability part, she had a GCS of 15 by 15, and pupils were equally reactive. And the exposure part, we look for any other external injuries, but appeared she doesn't have any other external injuries. It looked like a more isolated injury over the right ankle. And also she was given a blanket to cover the head to prevent hypothermia. And on reassessment, actually, her airway, breathing and circulation was maintainable, and her pain score has come down to 4 by 10. At this moment, actually, we went to the secondary survey and went for a detailed history. What happened was actually about 30 minutes back, she was playing basketball, and she had a sudden twisting of right ankle while playing, and she fell down. And after that, she was not able to walk, and the bystanders who stood by actually brought her to the hospital. And from that moment, she was complaining of pain and swelling over the right ankle. And there was no history of any other injuries, especially no head injuries, no LOC, vomiting, seizures or anything. And it was primarily isolated injury to the right ankle. And she doesn't have any previous allergic history, and she's not on any medications, and she also doesn't have any past medical or surgical history. The event that contributed to this was only this event. And on reassessment, actually, again her airway, breathing and circulation is patent, but now the pain has again went up to 6 by 10. And I give ketorolac 30 milligram IV in 100 ml NS over 20 minutes. And now I went to detailed examination. The systemic examination was normal. She was a moderately built and well-nourished female, and actually all of the systems appeared to be normal. So we went to the local examination. I went to the local examination. So in the local examination, actually on inspection, we went with anterior, lateral, and posterior examination. Anteriorly, the right leg appeared to be comparatively swollen with a deformity over the lateral aspect compared to the opposite leg. And actually, the skin was stretched and shiny. And on the lateral aspect, actually, there was a swelling obviously on the lateral malleoli, and left side there was no obvious swelling or anything. Posteriorly, actually, there was no swelling or any deformity in the foot area, and also she was able to move all her fingers normally. And on palpation, actually, there was
observation the position of the limb and the foot.
Actually, the examination finding the patient, the people should be able to visualize exactly how was the presentation. So what was the foot position, shortening, anything was there, laterally rotated, medially rotated, all those things.
Okay. On appearance, actually, the right ankle was actually internally rotated. There was obvious deformity visible on the lateral malleolus aspect compared to the left side. And and she was also able to move her fingers normally on the affected limb.
Sensation,
Sensation was also patent.
warmth and cold.
Warmth, actually, around that swelling, there was a slight increase in warmth on palpation. And so, superficial palpation, there was a small, slight increase in warmth over that area. And deep palpation, actually, we actually mainly examined 4 areas. One is medial and lateral malleolus.
Vascularity.
Vascularity was also preserved. We put a SpO2 probe on that area and it was showing 99% saturation. And also we examined dorsalis pedis and also posterior tibial, both were actually patent. Good volume.
Palpable.
Palpable.
Good volume palpable.
Good volume and palpable. And on deep palpation, actually we checked the medial and lateral malleolus. And actually she was complaining of pain on both areas, but the pain was more on the lateral malleolus aspect. And actually there was no pain on the navicular or the 5th metatarsal area. Mainly on the lateral malleolus, she was having excruciating pain on palpation. And after completion of palpation, again we checked the vascularity, dorsalis and posterior tibial was palpable. And at this point, actually the splint has arrived, and actually we kept the splint, and actually we sent the patient for X-ray. X-ray of anterior, lateral and oblique was taken, and actually X-ray was showing a dislocation of the subtalar joint.
How will you apply a splint?
Splint, actually we keep the angle in the neutral position, and actually.
But here you are not able to keep, no? It is already dislocated. So how will you apply the splint? No. So you said you will ask for an L-shaped splint.
L-shaped splint.
Principle of application of the splint.
Basically, the idea is to actually immobilize a joint above and joint below the affected area. So the L-shaped splint was asked mainly because actually we could immobilize the area in front of the joint and also the leg. So in the way it was appearing, in the way the patient arrived, actually we kept the over the splint and actually using a this thing.
Crepe bandage.
Crepe bandage or
Any padding?
padding was also given to support
Padding should be given. Padding. Okay.
And then actually we wrapped around the L splint to keep it in position.
How will you wrap? Very firm or tight?
Just enough to keep it hold.
So you have to allow some looseness because it means future go for edema.
Edema formation.
So you have to keep one finger like that inside and then over that.
What are moldable splints?
Actually, like a prime splint, actually. Prime splint.
Moldable. Depending upon the deformity, you can mold accordingly, and you can keep the limb in the same position. Because the main thing is that limb should not be moving. At the time of splinting, we are not trying to reduce and put the splint. What will be the dislocation? We are not trying to get back to the anatomy. We are just trying that the joint is not mobile and the patient is not developing that pain. That is our priority. And if the joint moves, what will happen? It can further worsen the neurovascular structures. So the aim is to stabilize that. Whatever be the way, you have to stabilize. So moldable splint, what is that? Depending upon the shape of the deformity, you can mold that splint and apply the crepe bandage. So that form, the splint will be formed and it will be kept in position. So these are our moldable splints.
So she came back after X-ray. X-ray was showing.
What will you all other things you look for? See, before application, immediately after application, you have to check for the motor, sensory, and then vascularity. Okay, sometimes during the splinting there may be changes. Okay, that you have to do, and periodically thereafter, if any changes, still it is being reduced, you have to take care. Okay.
So after splinting also the vascularity was maintained, and she was not complaining of any sensory.
Sometimes the splinting, before the splinting it may be normal, and then after the splinting it may disappear, or vice versa. Okay, good.
Okay, so at this point the X-ray has come in the system and was showing a dislocation of the subtalar joint. And so now actually we have given adequate pain relief, but actually this the X-ray showed.
What is the pain score after the administration of painkillers?
Second dose.
After second dose it was 4/10.
Even 4/10. Even giving it like.
After
IV Ketorolac.
IV Ketorolac.
Still it is 4/10.
Plus paracetamol.
Okay.
Okay. So basically the X-ray didn't show any fractures, but only pure dislocation was there. So we planned for reduction. Actually, at that time we also called for the orthopedic team for support. And
in an emergency room, so there are like in Tilani and all, there are given clear-cut guidelines where you need to call the orthopedic teams, where the emergency physician himself can reduce the dislocation. So can you elaborate? So you really want an orthopedician to come and do the reduction, or you yourself can do the reduction? When you can wait, where you cannot wait, which are the situation?
Suppose the patient is coming to the ER with the complaints of acute trauma and is having obvious neurovascular deficit, we should not wait for any consultation or orthopedician support to reduce the defect. So as early as possible, we have to reduce the defect to prevent any more compromise to the neurovascular damage.
Yeah, the point is that you can alert if there is an orthopedic team, you can definitely alert them. But they are in some procedure, they are getting delayed. There is no point in waiting because already the neurovascular deficit has started setting. So in that position, you yourself can go ahead and try reducing. So try reducing and keep the patient on a splint or whatever we think that is available. Okay.
So in our patient, actually we had a orthopedic team promptly available, so they came and saw the patient actually. So we planned for a closed manual reduction, and for that actually we went for a procedural sedation. For this patient, we gave 100 microgram of fentanyl and 2 milligram of midazolam. Midazolam was slowly given to titrate to the sedation, and then followed by 100 microgram of fentanyl was given. And the reduction was actually done by traction counter-traction method by 3 people mainly.
So you can elaborate on procedure sedation? No. So before procedural sedation, you already given her paracetamol and ketorolac. Now, what all before the procedure, during the procedure, what all things you needed to keep it arranged? All those things you can tell.
Now the terminology has been changed from procedural sedation to procedural sedation and analgesia. Okay, sedation is only when there is no pain relief.
Analgo sedation.
Okay, some procedures and analgesia.
So basically, we had diagnosed the condition as a dislocation, and we needed to reduce the dislocation. So we explained to the patient and the bystanders the need for sedation, and also we explained to them what can go wrong sometimes in case of sedation, and we took a consent from the bystander.
Informed consent.
Informed consent.
A lot of different consents are there.
We also explained to them
the what is meant by informed consent.
And informed consent difference.
Informed consent means actually we explain to them all the details, including the possible complications that can happen during the procedure and also post-procedure. And
alternatives are
alternatives.
all the possibilities, like all the treatment options available. Why we are preferring this option? Any complications that are supposed to be arising from, and like the chance of like failure of the procedure, and if so failure happens, what is the other alternative? That should be explained to the patient and the bystander in their language, wonderful language, like which they understand, and the consent should be in a written format in their language, duly signed by the patient.
Ideally written by them, that is the correct way. Ideally written by them in their language and signed and countersigned by an external witness who has not been the party in this case. So that is the exact way by which you need to take consent. Suppose this girl is 17 years. Okay, you said it is 18 years? 20 years. Suppose this girl is 17 years. So, is she ready to give the consent as per the Indian laws, or you need to get the consent from the parents?
Parents.
Legal guardian.
We have to either get it from the parents or the legal
18 years
guardian.
major.
Until she
They
becomes
can
a
give.
major, yeah.
So, in any other, suppose the parents are not there. She has come directly from her school and she is 17 years and she is in front of you. No parents, no guardians, no one is available at that point.
Teachers or principal or someone who has brought the...
It is all depends upon the capacity of that patient. If at all a pediatric age group, if you feel that this child has got a mental capacity and you can take consent from the patient itself in case of an emergency. If it is 17-year-old or 16-year-old, not a kid who is less than 15 years. I am telling about a child who has got mental capacity, who is able to understand what you are selling, capacity when able to understand and able to retain the content, and when asked they need to reproduce. So that means meant by capacity. You are telling the procedure and she is able to understand that, she is able to retain that, and she is able to reproduce the same thing, then we can tell that that person has got some mental capacity. So in this condition also you can get the consent from the patient. So these are the criteria, because these things all will happen. Suddenly this can come directly from school. Maybe they would have gone for a tuition or somewhere else they are bringing in. Nobody major is available, so no guardian available during that time. So you are right in doing, but unless and until you are documenting everything. And always verbal consent is not always valid. it is again a consent only, but verbal consent is not always. Whenever you are going for a procedure, the routine printed consent is again not valid. To be very frank, the routine printed format of consent is not valid. In a court of law, they can reject it. Ideally, the consent has to be taken at that point and for that specific patient, for that specific procedure, and detailed thing has to be explained for patient to patient. What are things is going to happen? What are the alternatives? She said, what are the alternatives? What are the possible complications? So everything need to be documented. We just say consent and move away, but consent is the most important thing, especially for emergency physicians. Sir, anything to add on?
No, procedure consent is different, and procedural sedation or anesthesia consent also separately we have to take it. Okay. So also for blood transfusion we have to take a consent from the patient.
Majority of the time, what we will just ask the bystander to sign in some paper. That is the usual. That should not be done. You have to clearly explain, ideally in their own handwriting, in their own language. The printable format, whatever is available, is not correct.
In a boarding school, if the parents are far away, the warden or the principal of the school can take the charge of the signing the consent form if the person is less than 18 years. Okay.
So in this patient, we took a informed consent. It was given by both, signed by both her and bystanders were signed the paper. And after that, actually, while preparing for the sedation and analgesia, we also arranged for drugs and RSI. This equipments were also arranged.
Then all resuscitation.
All resuscitation
equipments as well as
and also cardiac monitor and defibrillation was also arranged.
The most important thing is you have to anticipate at any time the patient may go for
deep sedation and airway compromise.
So we should be maintaining the airway and the breathing.
So considering the patient, we arranged for a 7.5 CT tube and resuscitation drugs. Everything was arranged. A crash cart was also placed nearby, and also she was connected to a cardiac monitor, and also supplementary oxygen was just kept aside but not started.
When was the last meal?
Last meal was about 4 hours back.
4 hours back.
And that was also asked, and
for suppose this meal was like 30 minutes back. Is it urgent to reduce it, or you can wait for another 2 to 3 hours? In this patient, there is no neurovascular deficit. So you wanted to wait for another 2 or 3 hours, or you want to straight away go ahead with the procedure. For the last meal was 30 minutes back.
Considering the injury, the chance of going into defibrilation is less. So actually, we can take it as
pain is still there. Like
the pain,
after analgesics,
the pain still hasn't come down.
So reduction.
This actually a judicial call, because actually the one thing is pain hasn't come down, and so that can actually be a indication for reduction. On the other side, actually
you have other options available without doing sedation.
Okay. We can go for regional blocks.
Region block. Can consider other options also. See, it always risk versus benefit. Here the patient doesn't have any neurovascular deficit. One. And pain, only thing is that is against this, pain has not decreased. Still having pain. So whenever a dislocation is there, the pain has to get reduced. So that is the one indication to go ahead immediately and reduce this thing. That is only one indication as such now. And the thing is that if it's like 30 minutes, 40 minutes, there is a high chance that there is a risk of aspiration. So you have to explain to the family regarding that very clearly. But if time permits, and if you are all other, we can think of other methods. Regional block, as you said, or else you go ahead with the sedation. But you have to little bit more cautious of your airway reflexes. So your selection of drugs should be key at that point. Sir, any comments, sir?
Correct, sir.
So this patient is young and doesn't have any comorbidities, so we could use for anything.
Pardon? Young and?
This patient is young and doesn't have any comorbidities, so we could have gone for any drug. Basically, in this patient, we opted for fentanyl and midazolam, which is readily available.
How will you grade the risk before procedural sedation? You said young and no risk factors. So whether you have got some criteria.
ASA criteria.
So what will be her criteria?
There are actually 6 grade, 0 to 6 gradings are there, and this patient will be come around 1.
You said 0?
And no comorbidity.
So you have to clearly document all those things. Whenever you see our procedural sedation note, all those things are there. What is the ASA grade? If ASA grade is high, what are the drug selection? The ASA grade is low. You have to have a clear-cut guideline for these things. You should not just say the patient doesn't have any comorbidities. You have to grade. All these are the standard accepted grading systems. So you have to use these things. Okay.
So after arranging all the resuscitative measures and also all monitors and everything, we give sedation and we give a titrating dose. Actually, we give slow push of midazolam until she went to sleep, and following that we give fentanyl.
Most importantly, a competent person to take care of the airway as well as the breathing part should always be available. If you are capable, you can go ahead. Otherwise, you have to keep somebody there who is well trained in that.
Suppose you are busy with the reduction, somebody should be there in the head end who can take care of the airway. That's what Sarah is pointing out.
And following that, actually, we go for a reduction using the traction counter traction method.
Dosages, can you just describe?
Dosage, actually, midazolam, the initial dose is 0.05 to 0.1. This patient we opted for 0.05. And titrated to that, actually, for the response of the patient, we gave only 2 mg was given. And Fenda, actually, 1 to 2 microgram could be given. Actually, for this patient, we gave only 100 microgram, for which she had adequate pain relief and analgesia. And we went sedation, and we went ahead with the reduction. Reduction was actually went again smoothly. And
want to give any antiemetics prior to this?
Antiemetic was already given.
What did they?
Antiemetic is ondansetron was given, 4 mg was given, because fentanyl has a chance for MSS inducing, and so it was also given. And then we went ahead with this thing CMR, and it was reduced. And after that, we put a
reduction. Just right. How did you do the reduction?
Okay.
Explain that.
Okay.
So how many people's minimum you need? So what are the methods? Positioning, where they need to stay. What is the position of the limb?
Okay. So the patient was placed in a supine position, and we had 3 people actually. One was holding the tibia using giving counter traction, and one was just supporting the heel and the area, and one person was at the foot and giving the traction. And with that traction, actually, the other person holding the counter traction, a pull was given, which was opposite to the mode of injury that happened, or against the direction in which the mode of injury happened. And with that traction, actually, the dislocation has come to the normal neutral position. And keeping the foot in the neutral position, a slab was
immediately after reduction. What is the one thing that you need to do before applying slab?
We have to check again the distal pulses for any neurovascular disturbance, and after that,
before applying slab, always remember, because after applying slab, we will not be able to examine those things. Okay. Then.
After that, we arranged for a slab. A POP slab was put. 16 layers were actually taken, and a POP slab was put below knee was taken. Mainly the injury was below the ankle joint, so the main idea was to immobilize the
up to what level?
The below the knee. Basically, we want to immobilize the knee and also the metatarsal.
Knee you want to immobilize?
No, not knee. Sorry, ankle. Ankle and metatarsal area.
Metatarsal area. Just above the metatarsal, you can stop. Or you can just toe exposed. You can
exposing the toe just above the metatarsal. We stopped this thing, and actually, and the back side just above the ankle joint.
Not just above the
not
ankle,
just above,
below the knee.
Below knee.
Because she should be able to bend the knee, all those things.
Basically, BK slab was put, exposing with the toes exposed.
What are the movements of this ankle joint? We'll examine for.
Like
not in this case, this is just dislocated. Otherwise, you have got a sprain injury. Somebody is coming with. So, what are the ankle joint movements?
Inversion. Dorsiflexion, plantar flexion.
Inversion and
Metatarsal.
Okay. And after putting the slab, we went to send the patient for a check X-ray. It was showing a properly reduced with no new fractures or anything. And after that, we covered the slab. We actually put a stockinette followed by a cast padding, and then put a this thing POP slab, and then covered the whole thing with a crepe bandage. And the patient was asked to review then after 2 days in the OPD for again reassessment, and the MRI was also planned later. Because the edema we are not planning for right now. And patient was given with analgesics and NSAIDs, and then sent home after observation for some time. Since we have given
after observation for how long?
The patient actually stayed back in the ER for about 4 hours post.
Where will you keep the patient? How will you monitor the
we
patient?
have
what will you do for this patient?
The patient basically
after the procedure is over.
The patient is feeling, I am feeling hungry.
Okay.
Can you feed? You feed.
Not immediately after a procedure, maybe after 1 or 2 hours we can, because the effect of fenda will wear off by around 45 minutes, and midas also the peak action will wear off by 1 to 2 hours. So after that we can give. Then also we have to intermittently monitor the patient for any drop in blood pressure or anything, because of the peak action of the drug which sits in.
Intermittently, or you should have a continuous monitoring place.
Monitoring is
5
placed.
minutes.
Yeah. So we can follow the trend in the
SpO2, respiratory part, and then BP. All these things should be monitored till the patient becomes completely recovered. What is meant by complete recovery?
Sensory-based patient is completely conscious oriented and all that, and then she is not complaining of any further difficulties like any not able to walk or any giddiness or anything.
She will not be able to walk in this case.
Okay.
The patient can himself or herself able to protect the airway and maintain the respiration without any assistance normally.
And also while sending the patient home, we have to ask them not to drive or go nearby any fire or any water.
She will not be able to drive.
Suppose after 2 hours the patient suddenly complains of pain going on increasing. How will you manage?
The first thing we have wrote in a compartment syndrome. We have rolled out. And
what will you do? First thing, compartment syndrome. We are suspecting. Immediately, what will you do? Remove the immediately. First, open it. And, that is the first thing. Don't delay any further.
What will be the other cause of pain rather than compartment syndrome?
One thing may be tight dressing also.
Okay.
Because edema formation can cause pain.
You would have missed an associated fracture. Sometimes it is difficult to see a fracture. Maybe we would have missed a fracture. Maybe the dislocation is not completely reduced. So, or it has got displaced. So these all things you have to keep in mind. So whenever somebody is coming in, compartment syndrome should come to your mind first. So are the discharge instructions given to the patient?
One is after going home, actually preferable to keep the foot end elevated. And also whenever possible, do toe movements. And also if any
weight bearing
after 6 weeks.
Okay. Partial weight bearing
after 4.
Ideally, the first initial 1 month should be ideally non-weight bearing. Ideally, and after that you can start with partial weight bearing with the help of a crutches and all. They can start doing that. 4 to 6 weeks is the ideal time. Then what are the instructions?
Then we send home with NSAIDs and anti-inflammatory medications, and also the patient has to review with an MRI, because actually in this area there is a high chance of ligament injury. So we have to do with a review MRI.
Which are ligaments?
Anterior talon ankylosing.
Almost all the ligaments would have got injured in this case. Anterior talon, whether spring ligament, deltoid ligament, all those ligaments, there is a high chance it can be more often a tear rather than a sprain. So there can be high chance. So definitely she needs an MRI and a prolonged this thing. Then what else you will tell her?
Avoid any high risk.
No. Immediately, what should be the instructions? Simple instructions. Whatever you are going to monitor after POP application. What?
Any
pain,
any
discoloration, difficulty in movement, paresthesia, numbness. Immediately report back to the emergency room. That is the main instruction that we need to give. That we should not forget that. Okay.
That's it.
Good.
Okay, thanks.